the first part is, well, what is the rationale for doing this? And that requires going back a little bit to the mechanisms of pain in migraine. The way I think about migraine now is it's generated in the brain, and after the brain is activated, efferents go out to the meninges, and CGRP is released and binds to a CGRP receptor, and then blood vessels dilate, and there's inflammation. And the combination of vasodilation and inflammation is what hurts in the meninges. It's a little bit as if every time a person gets a migraine attack, they have a non-infectious meningitis. They've got vasodilation and inflammation, and that in turn activates the pain afferents to go back into the brain and process this. And so the pain signals ascend, and people recognize the pain and get associated photophobia and phonophobia and nausea. And triptans prevent CGRP release and inhibit the pain signal from returning to the brain through a serotonin 1D agonist effect. And triptans vasoconstrict the blood vessels that CGRP dilates through a serotonin 1B agonist effect. Triptans can reverse migraine by doing that, but they don't have any anti-inflammatory effect. And remember, there's a neurogenic inflammatory component to the pain mechanisms that CGRP generates. Adding an anti-inflammatory results in termination or mitigation of the peripheral neurogenic inflammation. And NSAIDs have also been shown to work centrally in inhibiting and terminating central sensitization in migraine, in work that Rami Burstein has published. So it's possible that what you're getting when you add a triptan and an NSAID is both a combined peripheral anti-migraine effect and a central effect. And that puts into position the opportunity to give patients a complete response. What we're really after clinically is one and done. We want to treat, have them pain-free in 2 hours, not have significant side effects, most of the time not get a recurrence of the headache, and the combination offers that opportunity because the pharmacokinetics of combining these new formulations of meloxicam and rizatriptan results in the active ingredients peaking before the CGRP peaks, before the prostaglandin peaks, so that the entire thing can be shut down, and then there's a nice long action. So that's the reason why the combination should work. Adverse events were very low in the study. They were about 1% over placebo, but we all know that some people do get sleepy with rizatriptan. We all know that anti-inflammatories are contraindicated in people with peptic ulcer disease. Meloxicam has a warning not to be used after coronary artery bypass grafts. Triptans can't be used in patients with vascular disease. And in patients with multiple vascular risk factors, caution, I think, is warranted. I wanted to address what always comes up when we discuss combination therapies in migraine. Why can't somebody just take a generic meloxicam and a generic rizatriptan? Why can't the provider do that? And there are two answers to that are really important. One is that generic meloxicam has a very long time to maximal serum concentration. And it's such a long time to maximal serum concentration that generic meloxicam is primarily used preventively for arthritis. The mosaic meloxicam that's in the new medication has a quick peak in time to maximal serum concentration. And rizatriptan always is fast, but it's even faster in the mosaic formulation. So using generic meloxicam and rizatriptan is very, very unlikely to work like this combination medication. And in fact, when the individual components were tested, at least individually, they didn't work as well. But more importantly is a study that was published over a decade ago in which patients were told and given prescriptions for nonsteroidal amitriptan and told to take them together. And I think in this study that was published in Headache, only about 10% of them did it. So 90% chance they're not going to do it. They didn't fill the NSAID at the same time. They fessed up to not actually taking them together. If you, as a practitioner, really want the patient to take the combination to get the additive benefit, you almost have to prescribe the combination tablet. And that's what we've learned the hard way, and actually has been published in a very interesting study within the last several decades. So those would be my two admonitions about the new availability of this combination tablet.